Good afternoon, everyone. This is Tony Trahan with the Office of Mental Health. I want to thank everyone for coming today and attending this webinar on the opportunities for recovery and peer services in New York State healthcare reform. Just a brief orientation to webinars. Due to the number of participants, we do have to keep the lines muted, but we want to make this as interactive as possible. So please feel free to ask questions at any time via the chat function on the webinar control panel. We will be taking a break at approximately 2:15 to answer questions and do some interaction with you all. A copy of the presentation was sent out to you this morning. We'll send it out again for people who may have registered late or hadn't received it. The webinar is being recorded and it will be archived. We'll post this along with our other recorded webinars up on YouTube, and we'll send you a link and a follow-up email. Please feel free to share that link with other people in your agency. We currently have almost 150 people online. During the webinar, you may experience some momentary lapses in the audio. This is normal, and it should not interfere with the overall content of the presentation, but if you are having difficulty hearing over the computer, you may want to call into the teleconference. The number is in the welcome message on the control panel. When the webinar ends, you'll receive a short survey. Please take the time to fill it out. We will provide certificates for today's webinar if you need credit towards a certification such as a CPRP or a KSAC, or if you need proof of attendance for your work. Today's presenter is Harvey Rosenthal. Harvey has almost 40 years of experience working to provide or promote public mental health policies and services that advance the recovery, rehabilitation, rights, and community inclusion of people with psychiatric diagnoses or disabilities. Since 1993, he has served as Executive Director of the New York Association of Psychiatric Rehabilitation Services, also known as NYAPRS, a peer provider partnership that has successfully led numerous legislative and budget advocacy efforts and promoted the expansion of culturally competent recovery-centered services and employment initiatives. NYAPRS also developed the nationally replicated peer bridger model in 1995 and has since worked to bring peer bridging and wellness coaching to Medicaid beneficiaries, adult home residents, and criminal justice-involved individuals. Harvey currently serves on New York's Medicaid redesign team and its most integrated setting coordinating council. Harvey's interest in promoting mental health recovery is also personal, dating back to his own hospitalization at age 19 and a grateful life in recovery. And on a personal note, I just want to let people know that I have been fortunate enough to work with Harvey off and on for the past 7 years. I think he's a great person. He's a very passionate advocate. His knowledge of the system and his style, especially his humor, has influenced legislative and executive leaders. I respect him greatly for his dedication and achievements in making the rallying cry of nothing about us without us into something very real and tangible. So, Harvey, thank you.
Thank you, Tony. Well, good afternoon, everyone. This is a really critical topic for me, and what I have here is, it says the opportunities for recovery and peer services in New York State healthcare reform, but I would add opportunities for advocacy as well, as you'll see. I'm going to, okay, we're already stuck on a page, so Tony has instructed me how to advance it. And Tony, I think how am I doing? Okay, so you heard about NYAPRS. The importance of this slide is particularly around the website, nyaprs.org, or my email address. If you have questions, comments, complaints, you can send it to me personally at that address. And the website is chock full of information, including years of archives of our e-news, and even this presentation is already, I think, on our website. So, you know, as Tony said, I've been in some fashion sort of connected with mental health services or policy, either personally or professionally or as an advocate for almost 40 years, and I've never seen this amount of change happen, be in the process of happening with this amount of impact at this pace with so much at stake. And it will affect what services people get, from what providers, how will those providers be structured and what kinds of networks, what will there be expectations of care, For how long are people expected to be in services? How will providers be paid, and what will that say about what's important? How much information will people who are receiving the services get? How many choices and rights protections will they have? And how, given the fact that a lot of this is now being moved from the state to managed care plans, for example, how strong will the level of state oversight be over these major changes that affect so many people? So if we're going to talk about healthcare reform, and I'm going to move us from federal healthcare reform, Obamacare, the Affordable Care Act, all those interchangeable for me, and then how it's really on the ground here in New York under the term Medicaid redesign. Why are we having all these big changes? Well, it starts out with money. For years, government has funded a fairly unlimited amount of services, particularly in New York, where the Medicaid benefit is so rich and expansive. And, you know, Medicaid increases every year. There's no cap on it. It basically is based on, in most instances, you know, the demand and the participation in that. And so there's ever rising costs, and yet Medicaid beneficiaries have not been getting the right kind of health care, and you can tell that because the outcomes are really either not measured or are not always that great, and I'll talk about that in a minute. And the evidence of that, particularly from a cost and wellness point of view, is way too many people are spending way too much time in costly visits to emergency rooms and hospitals. So the response at the federal level, you know, federal Medicaid, the feds pay half of Medicaid, and New York pays almost half, you know, almost the rest of it. And both of those dollar amounts go up and up and up, and so we're really trying to get our arms around how that money is spent and with what impact. Starting at the federal level, I'm just going to scroll through this here. New York, you know, there's been complaints of our healthcare system that it doesn't perform as, given all the money that's in it. It's the biggest, richest healthcare system in the world, and yet it really does not perform as well. I think our mortality rate is higher than many countries, meaning people die rather than be helped into wellness. And a number of people really are getting care from lots of people for long amounts of time for a lot of money, but a lot of the care is reactive and illness-based, and rather than preventative and wellness-based. And you know, for a mental health advocate, and I think many of you would agree with me on this, that the way it's been in our system and the way it still is for too many people is we have a system that's really based upon the following expectations. And you know, when I worked in the state hospital here in Albany years ago, and even to this day, I hear people are being told, you'll never really recover. You'll always be in services. You'll always be on medication. You will regularly relapse. Don't work. You know, don't marry or don't have a family. Or if you do, you may not. You know, maybe you shouldn't be a parent. Really powerfully disabling sort of messages. And how it plays out with services is it says that people will be in services for all their lives, that they'll regularly relapse and require emergency room and hospital admissions, that they'll be on one or many powerful medications for most of their lives, that they'll never work and therefore be poor and live on entitlements. And the expectation often has been that people will not engage easily, or we won't work to engage them, and instead we'll label them as not compliant and all too often require mandatory treatment. So when you believe all these things, you construct a system that doesn't think twice about spending a lot of money on clinic, day, housing programs, emergency room admissions, hospital admissions, lots of medication. The checkbook on that is unbelievable, and it's based on an illness model and a chronic model that believes people will not get well, essentially. The cost to people are, as you would guess, people who accept a diagnosis wind up being poor, often idle, isolated, segregated. They lack hope, purpose, and community. And from a health point of view, as you know, we die 15 to 25 years earlier than the public, and often because of the wages of being idle, isolated, segregated, poor, and smoking, and sometimes our medications, which cause people to have obesity, diabetes, lung, and heart conditions. And of course, from the public's point of view, the taxpayers are paying an ungodly amount of money In New York State, the Medicaid program is $54 to $55 billion, more than many, I think, the next 2 or 3 states. And it said in a recent document that the behavioral health care system, meaning the mental health and addiction systems, are $8.7 billion. And that doesn't even include the amounts of money that are spent in jails, prisons, and homeless shelters and what have you. So we have, I like to say that on the positive side of things, we have a perfect storm for change. You know, I would add an extra slide if I had thought about it, saying, you know, there's been an imperfect sort of storm in recent weeks to months that really upset this apple cart. But from a positive point of view, there are financial problems around the country, and that's not a bad thing in some ways, because it means people want more for their money and they expect more. Government and the public expects more for those dollars. So that puts pressure on spending an ungodly amount of money for a chronic mental health system. We can't afford it and we don't want to. That's a good thing. Healthcare reform, both federal and state healthcare reform, requires a whole, it stands our system on its head. It makes it more coordinated. Now it's fragmented. It makes it more active. Now it's often passive. People sit in offices or in programs waiting for people to come in and fit into those programs rather than engage people individually. Services aren't taking the burden of being accountable and more engaging. We're integrating our services. We're making them more outcome-oriented. It's not just about visits, but outcomes. And in order to work, they need to be more person-centered and individualized. Those are all good things from a recovery point of view, driven by healthcare reform. You'll hear a little bit soon about, in this presentation, about we're going to managed care. And as I was telling Tony earlier, there is a flexibility that's possible in managed care and a willingness, actually, and to fund things that many of us care about: peer services, housing, employment, maybe even alternative treatments are possible. So there's some real possibility there. Another force that we're dealing with is Olmstead, which is a legal requirement on states like New York to serve people in the most integrated setting. And then, of course, you have all the way through the consumer and recovery movements. So if you take them all together, the recovery movement is happy to see that money has to be spent more on wellness than expecting relapse and life and services. Healthcare reform really expects the care to be much more accountable and outcome-oriented. Managed care comes with flexibility, but that gives some real hope and promise. Unfortunately, the slide I didn't think to bring in is, in recent months, with the outrageous link between violence and psychiatric diagnoses, we've really been dealing with a very imperfect storm around that with terrible consequences. But I won't deal with that today. You can see more at NYAPRS.org about that. Federal health care reform, the triple aim of federal health care reform is that services lead to outcomes, that they be the highest quality and the most modern, and that they are less expensive. They reduce avoidable costs. That's done sort of around the country on expanding Medicaid, as you'll soon see in the out years of health care reform, much more use of managed care, and along all those, an expectation now that mental health and addiction should be offered as often and as much as health care are. And we have here in New York to thank Tom O'Clair, the fellow in the office next to me, for seeing that happened here in New York with Timothy's Law. Needs to be a focus on better coordinated, accountable, integrated care. That's, from top to bottom. More of an emphasis on services in the community, more of an emphasis on wellness, on prevention, and really there's a lot of term you'll hear it about upstream, working with people before problems occur and earlier in their lives. And then, of course, a focus on individualized care, person-centered. Here's a perfect example of, here in New York, how the money is spent in a way that really makes it clear why we need to do something different. New York's Medicaid program serves 3.5 million actually of people on direct sort of Medicaid and another 1.5 million on other forms of Medicaid. The total cost is $54 billion. I think it may even head to 55. But check this out. 20% of the people on Medicaid use 80% of the money. 1/5, 1 million of the 5 or some portion like that use most of the money. And guess what? 40% of them are people with mental health and addiction issues. So that means That's terrible news, but on the positive side, it means that the healthcare system is looking very deeply at what do we have to do to promote wellness and mental health and addiction, because too much money is being spent there in hospital emergency rooms, medications and such. And check this other fact out, that New York is 50th in the country, the bottom, in the number of avoidable hospital readmissions. And of those readmissions, 70% have mental health or addiction sort of issues. And in that group, 3/5 of the time are for medical reasons, which doesn't surprise you if you recognize the amount of medical issues that are unrecognized and untreated amongst people in our community. And for all the money that's being spent in the Medicaid mental health system, not only are people sick and spending a lot of time in the wrong places, but they're vastly unemployed and make up a high proportion of people in homeless shelters and prisons and jails as well. So lots of money spent, not enough outcome. This time we have an ally, though, a powerful partner. We, the recovery movement, haven't wanted people to be in chronic care or spending time in the emergency room or hospital that could be avoided. We don't want to see people on too many medicines all their lives. Well, we have a powerful ally, Governor Cuomo. And his administration and their emphasis on Medicaid redesign is all about spending money in the right place and having services be much more accountable and much more outcome-oriented, and prevention, wellness, and even, as you'll hear, peer support. So the governor developed the Medicaid redesign team, which originally put everybody on that team that normally would fight the cuts to Medicaid, and said to them, look, work together and improve the program or I will cut it heavily. And they came up with 76 or somewhere between 76 or more sort of proposals. And the focus is on integrating services, as you can imagine, and all the things we've just talked about, coordination, collaboration, accountability. And there are a couple of strategies in our design plan that really are the most preeminent. Health home networks, which I'll talk about next. Integrating all of these services in Medicaid. Right now, many of them are separate. Putting them all in one pot and under one system under managed care. A focus really on outcomes, not just how often you get services. And as you'll see in this, and actually we just saw in the recent budget, the beginnings of putting Medicaid all together in one pot. Right now, Medicaid, there's separate Medicaid and OMH, the mental health budget and the addiction budget, in other budgets, and they want to put it all under one budget. That's part of Medicaid redesign. Health home is one of the real strategies that we've already been rolling out already the last couple of years. And it's being done sort of nationally. I think 8 states, it's a key element in healthcare reform. And I think 8 states are currently on the ground and implementing them. New York is one of them. And a health home is not a house. It's really a hub. It's really a network of care, a network of services. It's a multidisciplinary team, and within that network are medical providers, mental health and addiction providers, and even in the network are social service organizations, housing, religious groups, disability groups, independent living centers, all together who are supposed to work together to improve care and reduce costs for people with more serious conditions. Health homes are for people with more serious ongoing sort of conditions, sometimes called chronic, as opposed to person-centered medical homes, which are really for people with less chronic and more private pay sort of people. Health homes are more about Medicaid. The way it works is one agency is appointed as the lead, and it comes together with a network, and it applies to the state, and in many instances they get selected. The health home is saying, I will take a monthly payment from the state, and I will coordinate the care and make it accountable, and I'll get my network to work together in service of one plan that's supported by one dedicated care manager who really works for that one individual, each individual, and works together to see that all the service plans are coordinated and shared with all the providers through an electronic health care record. And if I forget to say this later, advanced directives, which are rarely used in healthcare, have a real chance of being preeminently seen, very visibly seen through an electronic health care record. So that's, I think, a real opportunity. Health homes have the goal, as you're going to hear this again and again, keeping people out of hospital and emergency rooms and nursing homes whenever possible. So one little side sort of tidbit I want to say is, any of you out there that have a strategy that you can demonstrate that'll keep people out of hospitals and emergency rooms, this is your time. And, you know, it has to be really well explained and data supported and well staffed, but that's the mantra right now. And part of that is active engagement, 24/7 response, and at key moments there has to be a good handoff, a good sort of discharge plan. Too many people leave hospital. The outpatient teams don't know about it. Mental health, the medical teams don't know about it. All that's supposed to be integrated to help the person and to reduce avoidable relapses and expenses. As I said, they get a monthly rate, or the health home leader gets a monthly rate. All the providers in the network do not get, at this point, any additional funding than what they were getting prior to being in the network. But it's in their interest to be in the network, to provide better care, and to line themselves up for the future, which I'll explain. So here's an example of one. This is an out-of-date one, but I wanted you to see what a health home might look like. So this is in the Hudson Valley. This was an earlier application. So a health home in this case consists of several hospitals in that area. There's a health plan in there that sort of pays the bills for the providers in many instances and funnels the money through to the care management. Hudson River Healthcare is the operator of the health home, and it assembles these hospitals, works with the plan, has a number of medical providers. Most plans have many, many, many medical providers. I picked a smaller one just so you wouldn't have to go pages and pages. There's a variety of miscellaneous kind of services. You'll see aids, developmental disability services, housing programs, etc. And here's the behavioral health providers. So all these behavioral health providers in that area, whether it's county mental health departments, DD providers, mental health associations in that area, not-for-profits like RSS and Occupations and Putnam Family, all of them are part of the network, Westchester Jewish Services, etc., county mental health. So why is this in the interest of consumers to be a health home beneficiary? And by the way, you'll see that consumers will be automatically assigned to a health home. They can opt out of it sort of later, but if you're in an area where a health home is coming in, the state is going to auto-assign you to a health home with the idea that you'll get what's on this slide: better integrated care, help with navigating your healthcare system. It won't be this morass of providers with all kinds of treatments that are maybe hard to understand why and what they're going to do and how they work together. There's supposed to be better access to make sure you get in and the providers respond. Services are supposed to be better coordinated. They're health and wellness focused, not illness and deficit focused. They're supposed to be. And it's supposed to help you really acquire the skills to be healthy. Providers, as I said earlier, really want to be part of a network because that's where things are going. That's where the future is going to be. And it'll help their efforts to serve people. They'll also get more referrals because as the health home proves its worth and gets more referrals, and a provider in the network proves their worth, they'll get more referrals. There is this, that people work together with an electronically shared plan, and it helps everybody focus on outcomes. So I'm going to skip this slide. So there is I read a lot of your comments about what you were hoping I'd comment on, so I'll start right here. There is an opportunity for peer services in health homes. Remember I said there's only one real stream. It goes through the health home, and it usually pays for care management. Well, the health department has made it clear that a health home can reprogram. It doesn't have to use that monthly care management dollar to just buy some sort of care manager or caseworker or social worker. They can use that money to buy peer services. They're not in many instances, but they could use it for outreach and engagement, for bridging, for wellness coaching, for crisis relapse prevention. These are very important functions that health homes will want and need, and managed care will look for. And right now, a health home could buy it. They're not, but they can, could, and should. And one way NYAPRS had a demonstration of this. We were in a demo project in a precursor of a health home in Queens where we worked with the Optum. In this case, it was Optum Health. We were part of a triangle working with the care manager and the nurse and the peer wellness coach. And really, we We maintained our integrity. We worked for the person. We really acted as a sort of a coach and a supporter and an advocate, and we helped really link them to nursing and care management. Keep going.
Excuse me, Harvey, just for people who may have come in late, could you just give just a brief summary of what NYAPRS stands for and what it is?
Yeah, NYAPRS is a statewide partnership for 30 years now. It's peer-led. I and most of my staff are peers, and what we do is work in a number of strategies to promote recovery, rehabilitation, and rights, mainly advocacy, education, training, and new service development, employment, and cultural competence, and things like that. Thanks. Sure. Health homes are phasing in or have been phased in a number of parts of the state. In phase 1, you see the 10 counties up top. They're already up and at them. They're phasing in phase 2, and in phase 3 is coming in. So this will eventually be in every county. And again, the state puts out a bid, a request, and health home leaders assemble these networks and apply and are selected. And a number of these counties have 1 or more health homes. Currently, there are 50 health homes in 57 counties serving 16,000 members. According to the health department, the homes in phase 1 and phase 2, there's been a problem in seeing enough referrals to the health homes. Frankly, the managed care plans have not really done the referrals, have sent over enough referrals to the health homes, but the health department's worked hard on that. And they're expecting another 62,000 will be sent over and referred. They expect to enroll 76,000 by April of this year, 151,000 by April of next year. And I'm wrong on the ultimate goal. I just got an email from the health department. It's 250,000 is the ultimate goal, not 90. So cross that out. And in the next few weeks, you'll be hearing, or months, there'll be the health homes in Albany County, Delaware, Schoharie, Shenango, and Otsego. So be ready in those counties. Here's the other. So you see health home networks are basically on the ground ways to better organize care and make it more effective, more responsive, more outcome-oriented, more engaging. And that's really a huge strategy for healthcare reform in New York State. That's going to be around. That's the future, is providers working together across disciplines in a coordinated way and in an accountable way. Remember I said the providers in that network currently get paid the way they get paid now. Well, mental health providers are currently carved out. Well, actually, let me get there in a minute. The healthcare providers that most people on Medicaid are getting, the health services, are already in managed care. People around the state, many of the folks you are or serve, are getting their health care through managed care plans. Plans like Fidelis, Excelis, Health First, HUDSON Health Plan, Capital District Physicians Health Plan, you name it, Affinity. These health plans are around the state, and they're already providing the medical care for people. And as you know how managed care works, the managed care plans really identify authorized providers. They authorize the treatment plans, and they pay for them, and they review them on a regular basis. And their plans and providers are paid on a monthly basis with a goal of meeting certain outcome targets and saving targets. Right now, mental health services in Medicaid, at least the ones at OMH, like ACT teams and case management and housing and PROS, things like that, are carved out, meaning people go to them on their own choice. They're not managed. You go to them, you go as long and as often as you want or are expected to go. And those providers are paid on a fee-for-service basis, which means they get paid for every visit rather than, and irrespective of outcome, really. And the problem with that is when you pay people based on the number of visits, guess what? They have you visit a lot, sometimes whether you need it or not. So we're changing from that system. Also, one of the restrictions we have in fee-for-service and in traditional Medicaid is it's been interpreted to be very restrictive and very medical, that there has to be some sort of medical necessity for you to get the service, and it usually sounds like an illness and a symptom sort of treatment. And as you know, that's not about recovery and wellness and rehabilitation. And so I'll talk about where there's some hope in managed care to relax those restrictions. And there's really no incentives right now in fee-for-service, and there isn't a lot of coordination even within the mental health system, let alone mental health and addiction, let alone mental health, addiction, and medical care. But New York is planning to carve in Medicaid behavioral health services. So health plans are already managing the medical benefits and, as you may know, the pharmacy benefit, but soon the mental health and the addiction benefit is going to be turned over to them. And they will get a larger sort of capitated or monthly payment that will now include mental health and addiction services. And again, plans will then authorize the payments, and they'll basically say to you, to some degree, here are the providers you can use, and we want to kind of look at your plan and say, well, why are you going there? What's the outcome of it? Are you satisfied? Are we satisfied with it? And is it cost effective? Because the plans are accountable to the state, which is expecting now those kind of standards. We've just come up with a new name for so we're heading for what's called Phase 2, which means Phase 1, Medicaid redesign was mainly the health homes, you could say. Well, Phase 2 now is looking more broadly at how Medicaid is all put in one pot, as I said earlier, and given to to managed care plans. In New York City, they're now naming them health and recovery plans. They had this term, fully integrated special needs plans, but it sounded pretty complex. So they came up with a simpler term, and they've made it a little more flexible about how the HARP can operate. But it's going to integrate everything in one plan. In New York City, the HARPs, which could be run by health plans if they demonstrate that they can do it, they have the option of using a specialty behavioral health organization. I'll talk about them in a minute, like Value Options, Magellan, Optum Health, Community Care, Beacon, groups like that. They'll have the option, but they don't have to. Whereas upstate health plans will, at this moment, have to come in with a BHO. So in the city, it's all carved in one pot. Upstate, right now, a health plan the money will flow through a health plan, which could hire a BHO to manage the addiction and mental health benefit. I'll explain that a little bit. It may sound like a little complex. There is this policy now in New York, as we do this, to lessen the disruption of health care. And what that means is they want to basically find a way to not move people out of their current medical care, which to me means that the big health plans that are currently serving people on SSI, for example, probably have a big leg up on being the lead in these HARPs, because if they're not going to move, they don't want to move people out of them, and some of these plans have a lot of people in them, then they're probably going to have a great advantage. So to use New York City as an example, I went online and I found that these are the medical plans in New York City, and these are the numbers of people they're serving on SSI, a number of them SSI for a mental health disability. So for example, you see Health First, you see Metro Plus, which is affiliated with Health and Hospitals Corporation, you see Fidelis, or the Catholic Health Plan, you see AmeriGroup, you see Emblem. These health plans probably, and this is my opinion, have a leg up on, if they're not going to move people out of health plans unduly, and then there'll be some finite number of HARPs in New York City that will probably be led by some of these plans. That's just my opinion. Just wanted you to know. Managed care companies, and there are some opportunities in managed care that I think are very exciting. You can get beyond these tight medical necessity restrictions. The money is more flexible. It comes on a monthly basis to the plans, and then the plans in turn can buy services that are much more flexible, much more recovery and wellness oriented. And they can even buy, as you'll see, peer services, even other things that I'll talk about in a minute that are right now Medicaid doesn't pay for, but managed care could. So managed care Medicaid is much more flexible. And if it's in the contract, if the state, when they take all this money and bid it out through what's called an RFP, request for proposals, and eventually award a contract, if the state puts this in the contract, managed care has the flexibility to pay for any number of things that Medicaid doesn't easily pay for now. For example, what we call the social determinants of health. We know that if the goal is to keep people out of hospital, people that work, John Allen has a study on the buy-in, 50% of people on the Medicaid buy-in use 50% less Medicaid. So employment becomes important to a health plan that wants to show savings and outcomes. Housing, people that have stable housing, high numbers of success staying out of hospital. People, ability to serve minorities, which is very poor right now in New York. That's going to be a big savings. That's in there too. Peer services, clubhouse services, crisis services, these more flexible, non-traditional uses of Medicaid are possible in a more flexible managed care environment. And here's my favorite, and I think OMH is really considering this, and it is probably the most transformational thing possible. Taking the money that usually people access through providers, money that's given to providers, that are given in budgets to consumers to buy the things they need. So that includes emergency housing supports, health club membership. In some states, they're doing this in Medicaid managed care. People are buying alternative treatment. They're hooking themselves up to the internet. They're going to health clubs. They're doing the things that really matter to them that have nothing to do with going to a program. They're about just fixing their lives and making it more wellness-based. As I said earlier, there's these health plans of the kind that I showed you on these lists, and but then these health plans tend to subcontract with behavioral health groups, which are specialty managed care groups that have expertise in managing the mental health benefit or the addiction benefit. And you see the names I said earlier. The big ones are Optum Health, Value Options, Magellan, Beacon, Community Care, a group called APS, and probably some other ones that I didn't include. Well, look at what some of these have done, and this is not an advertisement for any one of them, but I want you to know that some really exciting things can be paid for through Medicaid managed care and that BHOs are consciously looking for and funding. So peer bridgers, which are trained peers that help people successfully transition from hospitals to the community. Optum has taken its money and bought peer bridgers in Wisconsin, Tennessee, New York, New Mexico, and other states. They've erected peer warm lines and crisis respite programs and bridgers in Tacoma, Washington, with great outcomes. So look at what managed care is willing to do. In Pennsylvania, Magellan is doing that self-directed care program I mentioned, and they're giving consumers $3,000 or more a year to pay with the flexibility to pay for the things they really want and need, untraditional things. Magellan also has recovery innovations and other crisis alternatives in Arizona, and they launched a managed care pilot some years ago in Iowa on psych rehab. Community care here in New York, it does a lot. They have a recovery institute. They train providers to be more about recovery. They take that responsibility. They set up learning collaboratives. They reinvested Medicaid money to buy $60 million worth of housing. You don't see that every day. And they set up consumer family satisfaction teams. Value Options has done a very exciting self-directed care program in Texas where consumers are spending as much as $7,000 a year on things they want and need. It's a well-managed program. People are not buying drugs and alcohol or anything that you might think they buy. People buy the things they really want and need and that are part of a plan. They're also paying for peer services. And not only the BHOs are interested in peer services, for example, but health plans. Those health plans I mentioned earlier, they're really looking around now for peer services and alternatives. And other groups are now getting hip to peer services. Hospitals are bringing peers on in their own programs. Medical providers are looking for peer wellness coaches, hospitals for peer bridgers, for example, and providers on the ground. The behavioral health providers are hiring peers all the time. Have you ever seen a time when peer staff are in such need and desire? Now, there's a question about the integrity of peer services, and I'll get to that a bit later. I want to talk a little bit more about peer services because so many of you asked about it. Peer services has a long history, 30, 40-year history, and started out really more from a rights protection point of view. It was a change agent, a revolutionary force about advocating for people and helping them gain power and take control over their lives, and often to push back against the medical model and the control and the illness-based and the low prognosis that the mental health system had for people. And peer service has grown now to go beyond just rights protection, advocacy, and empowerment to a discrete number of services that bring hope, that promote wellness, that advocate for people's rights, but that really enter into the healthcare system. So rather than just being on the trying to get people out of a mental health system, peer services are now being seen as an important way to help people get healthy and even play a role in the healthcare system. Again, the question is how you do that. And so we really need to be talking more about specialty services. I, for one, am very troubled about this term peer specialist, which is a generic term which, frankly, doesn't necessarily say a lot about what people do, and all too often providers are hiring them to do any number of things that many of us would not think are real peer services, that really use the principles of intentional peer support. Too often it's, it's going out and getting people to take medicine irrespective of the relationship. It's driving people to appointments. It's doing things that are not really what peer support came to do. So that's why I argue, and many of us, and Amy Colasante and many of us as part of the Academy of Peer Services, and many of the peer leaders in New York are really wanting to protect the integrity by and demonstrate the sophistication that we now have in peer services. Peer specialist doesn't say a lot, but peer bridging does. That's pretty clear, right? You're supporting people to move successfully from hospital, jail, adult home, nursing home, what have you. Very much in need, very clear. So it has some real competencies to it. It's a real specialty. It's a real profession, Peer crisis diversion, people that answer warm lines and work in respite houses. That's a very clear specialty. That's an expert. That job has an expertise to it. It's not something that can get easily sort of co-opted as well. Peer wellness coaching, where you go out and engage people, bring services to them, start with them, develop a RAP plan, and help people figure out what they need and want. They may want you to drive them to a doctor's appointment and help them with medicine, but that's not where you start. You start with the relationship and the RAP plan. There's rights protection and advocacy services that are growing up. And, in Medicaid managed care, there's a new ombuds program, which is exactly sort of an advocacy grievance and appeals program, and there's room there for peers to be hired there to do rights protection and advocacy. John Allen is very big on life coaches, which has a lot to do with helping people realize their employment dreams and learn to manage their money and they successfully integrate in the community. And there's peer-supported housing and employment services as well. So you see, this is not this generic peer specialist. It's a real discrete, sophisticated, fully professional kind of model. And let me tell you, that's what's needed, and that's what's going to sell in managed care, not some generic peer specialist sort of position, in my mind. As part of the Academy of, actually the Coalition to Protect the Integrity of Peer Support in association with the Academy of Peer Services, which is funded by OMH, put together a fact sheet recently where we really try to be specific. If we really want to protect and define what peer services are, and we want managed care plans to understand what a high standard of them are, these are some of the definitions. You'll see them on the website. I'm not going to go through them in great detail now. I've kind of summarized them a little bit already. But peer advocates, peer wellness coaching, peer bridger services, peer crisis services, peer services have really arrived as long as we really define them really clearly and recognize the competencies that are involved, the outcomes that they can do, and frankly, folks, the real careers that they provide people. These ought to be full-time jobs with real careers. The average annual salary around the country for these kinds of jobs, according to Pillars of Peer Support, is $37,000 a year. So we're not talking anymore about entry-level jobs under the cliff of SSI, and we're not talking about low-pay jobs wherever possible. Peer unsupported housing, and peer employment coaches and life coaches. So you'll see more about this online. You'll see it at the Academy of Peer Services.org, I think it is, or .com. I should know this, but I don't. And you'll see it on our website, NYAPRS, and probably the OMH website as well. And also peer recovery centers, which are growing throughout the state and have their own sort of definition.
Yeah, it's academyofpeerservices.org.
Thank you. Thank you, Tony. And the Academy, here it is right here. In 2012, we kind of bumped our way through to really come out with, let's really identify core competencies that every true peer worker should have. RAP, engagement, starting where the person is, rights protection, real skills, and then let's even define further what these specialty workers, what competencies they'll have, the bridger, the wellness coach, the crisis worker, the housing worker, the employment worker, and done in the way that peer services are done. In 2013, I think you'll see that we'll be developing, the whole academy, which includes UMDNJ, University of Medicine Dentistry of New Jersey, who's the sort of online sort of hub of this thing when it comes to the curriculum, and then other groups. NYAPRS is in there, Mental Health Empowerment Project. Many of the leading peer programs are going to be in there as trainers. So we're going to pull together this training. You'll see it online. You'll see it locally in regional communities of practice, and you'll even be able to ask for individual TA from some of our experts. So be on the lookout for that. If you're marketing peer services, if you're going to really demonstrate the power of peer services, you have to have data. And so we do have data now that shows that peer services have substantial results. And this is the kind of data that gets the new payers really interested, managed care plans in particular. When you tell them things like this, they say, I want to buy that. I want to do that. I want to bring that to my area. I think it'll be good for people, but it'll be good for business, because recovery is good business, because it saves dollars and helps people get well. But it keeps people out of costly settings, as I said earlier. So Rose House, Steve Miccio's program out of Ulster County, I think, is where it's housed. They have data that shows that people that went through that program, and I don't have the percentage. I think it's 90%. I apologize. 90% of people went through that program did not return to hospital in 2 years. Remember I said we have a high readmission rate. So to say that 90% of people didn't return at all to the hospital is profound. That is really good for people and very attractive for marketing and contracting and payment in a managed care environment. Our Peer Bridger program, we demonstrated some years back that we helped 72% of the people that work with us not to go back to OMH state hospitals. And now we're working with, in this case, with Optum in New York City and Long Island, and we just learned that we were able to, we said we would try to help people that were frequently being readmitted to the hospital, that we would help them drop their readmission rate by 40%, but the results are we're doing it by 50%. So look how powerful that is, and look how helpful it is to people. Help them have a life outside of hospital, and to have a different response when they're going into a potential crisis, or how to avoid a crisis. PeerLink, which is an outgrowth of Peer Bridger, Optum sort of renamed the Peer Bridger program and took it to other states. And those programs, look, they dropped hospital days in Wisconsin by 71% and in Tennessee by 41%. That's a Yale study. So these are real studies. I think Steve's study up top is College of St. Rose. The Bridger program we had National Health Data Services do, or Optum. So these are not just program eval data. These are actual research studies. Mental Health Peer Connection in Buffalo, Maura Kelly's program, has helped 53% of the people who asked to go back to work to help them get back to work. How phenomenal is that? And Housing Options Made Easy, Joe Woodward's program out in Western New York, those people that have gone to his supported housing program have not, 70% of them stayed out of hospital for at least 1 year. These are very powerful outcomes. If we're moving to an outcome environment that helps people and saves money, can you see how each of these models, each of these programs are really right on time right now? So peer services can play a crucial role, but we have to step up here. If we're going to play this role, this transformative role in the healthcare system, and bring those attitudes and that wellness and that hope to the healthcare system, then we really, if we're really going to get state government, managed care, and health homes to value us, then we really have to be successful in getting our programs understood and valued. And we have to probably step up our business end of things. The Academy of Peer Services is very focused on that. Do we have good liability insurance? Do we have good cash flow, good documentation, privacy protections? There are lots of things we have to do that maybe we're not doing quite as clearly. We definitely have to describe in clear terms. When you're going to talk to a new payer, you have to say, here's my model, Here's how it works. Here's who it works for. Here's what we think it can accomplish. This is what it costs. And by the way, here's the data that should make you think that it's actually going to do what we say it's going to do. We can do that, and a key outcome is keeping people out of hospital and emergency room. People will be very interested. We're seeing that, and many peer programs are seeing that already. But we have to, we're going to have to, again, be able to describe what we're doing. We have to have clear training and professional standards. We can't be quite as casual and vague as we've been. And we really need to be careful to promote the integrity of peer support. We're not just trying to get business. We're trying to help people get well and change the mental health system and the healthcare system. And we're not going to do that by taking, sort of co-opted jobs and just fitting into the medical model. So that's really critical. And imagine if we can promote self-directed budgeting and alternatives. If we can prove that we're valuable as wellness coaches and bridgers, those plans will come back and say, what else you got? And we'll say, how about self-directed budgeting and alternatives? So an example of the business case with a managed care plan around a peer program, peer wellness coaching is this model where trained coaches that are trained in the 8 dimensions of wellness, in RAP plans, in all the basics of engaging people, person-centered support, relapse prevention, connection to community resources, employment, benefits advisement, fiscal and health literacy. These are all that come with wellness coaching. And a big part of it, when you're making the case, you say, I can help find and enroll people that normally either are not organized, either are reluctant to get help, are not sure about it, don't have hope, are hard to find, have disorganized lives and need help to come to them and make a relationship with them. I can do that as a wellness coach. I can help that member identify some goals that they're actually going to follow through with because they're their goals. I can provide that follow-up coaching and help them meet those goals. I can help them develop a relapse prevention or a crisis plan that will help them stay out of hospital and emergency room. And I can advocate for them and educate them. And I should just say to peer programs, when you're talking to these plans, come in with what you think you can do, because a lot of these plans and some of these providers don't know peer support. And if you ask them, they'll give you something you don't want to do, you won't want to do. So you really have to know what you want to do and how it's going to fit within the environment. And you've got to propose it and stay on it, because otherwise you will be co-opted. Here's an example of data. We had a peer wellness program in Queens, as I mentioned. We worked with a guy that had, in his mid-30s, he's a person of color. He had all 3 conditions. He had a serious drug addiction and alcohol problems. He had a problems with mood, and he had major sort of health problems, including kidney problems. In the year before we worked with him, he had 7 inpatient stays at 4 different facilities, most of them detox. Medicaid paid $52,000 that year for his care. So he wasn't well, and taxpayers spent a lot of money. We worked with him. Our coach visited him, kept coming back to the house, made a relationship with him, helped get him into a rehab of his choice, visited him there, picked him up there, took him to her 12-step meeting, continued to work with him. He went from 7 detoxes to 1 rehab in a year. His Medicaid dropped from 52 to 20. Great for him, great for taxpayers in the state budget, very interesting to managed care plans. When you tell that story, everybody understands the power of peer support. Now I want to switch to advocacy, because advocacy is really critical at this moment. The Coalition to Protect the Integrity of Peer Support, really shepherded by MHEP, really sat in as the Medicaid.
What does MHEP stand for?
Mental Health Empowerment Project here in Albany. They do a lot of statewide work, but they really sat at the table. So did NYAPRS and so did other groups, but MHEP was really critical to convincing the health department, which didn't know from peer support, but was interested in it, had seen what peer wellness coaches like the ones we had were doing, and they said, maybe this is something we should look into. Let's form an MRT, Medicaid Redesign, work group on peer services. And Amy and them and that group got the health department and the governor's recommendations, the Medicaid Redesign team, to say, bullet 1, peer services need to be valued. Number two, we need to find a way to pay for them that really give them the flexibility they need. We probably need to come up with some standards for them. And yes, health homes should really have them in there. So those are four. That's in the governor's Medicaid redesign plan. Now, those of us that are also advocating, the state has a behavioral health work group that's doing a lot of advocacy. And this advocacy, I think, is critical. Remember I said earlier that it's all that's in the contract. It's all that's in the state needs to set rules for the flexibility that's in managed care. And unless they're really clear about what's expected, then we could see a collapse of the mental health system because our money is going into a pot and our services are being integrated. And some of us have learned a great deal. Traditional providers and peer providers learned a great deal about how to engage and succeed with people. That's got to grow, not shrink. It's got to take its place, not be lost. So we're advocating that these services, the services in the whole HARP, the health and recovery plans, they have to promote recovery and wellness and teaching people about their health care and promoting people to manage their own health care according to their own wellness plan. That's got to be right in the plan. The managed care plan, when it takes money, has to see that that happens. It has to be defined more clearly. We want to make sure that people are guaranteed their informed choice and privacy and other rights protections, especially if there might be some auto assignment. People might be assigned to health homes and maybe at some point managed care plans. They can opt out, but they'll need help figuring out which plan to pick or what it means to go into a plan. Sometimes that's called enrollment brokers, which could be peer advocates. And once they're in the plan, they'll need help figuring out if they're not happy with it or they need to advocate. That's called ombuds workers. And there is money in this year's budget for ombuds workers, but we have to work to make sure that enough of them are peers who better to advocate for somebody. We want to make sure that people have access to their electronic healthcare record. God knows it's going to be shared more broadly. People should know what's in it. And as I said earlier, advanced directives is a great opportunity for that. Here's a really big one. We're going to keep people in a hospital and emergency room. We're going to save the state a lot of money. A chunk of that money, a good chunk, has to be put back into promoting the kinds of things that are going to really keep people well, help people get well and stay out of hospital. And for us, those are peer services, housing, employment, things like that, things that Medicaid could pay for and that could be ramped up with reinvested sort of savings. Specifically, we need the state to tell the plans they need to buy peer services, flat out, that they should play a prominent role and with real integrity and define that. And that the state may in turn want those peer services to demonstrate that they have real competencies and meet certain standards. So we need to be ready for that. We need to make sure that people have access, those people that want to take medication, get the medicine that they and their prescriber believe really is good for them and that they want. There are real restrictions when you go to managed care. There's 21, I think, health plans in New York. Each of them now are managing the pharmacy benefit. Each of them have their own lists of drugs that they'll pay for and they won't pay for. We got to make sure that people just get the drug they need, not the ones that the plans will pay for. And there's things we're talking about with the state about that. Cultural competence, you can't say enough about it. The bad news is too many people of color, for example, and minorities, are poorly engaged and wind up instead on the streets or disproportionately in the homeless, and making up the homeless group, or are in jails and prisons or hospitals. So if you're trying to reduce costs, the good news is if the new environment, it wants real outcomes and wants to reduce costs, and these groups we're spending a lot of money on not succeeding, then we need to really emphasize cultural competence. It's in everybody's interest. And we're asking that there be what they call 1959, I won't explain that today, but that there be real flexibility around self-direction and flexible recovery services in managed care. One of the ways you do that, so what I've said, to some degree I've just been talking about the benefit package, peer services, employment, housing, things that are normally not in the benefit package of managed care. Managed care usually pays for traditionally medications, clinic, hospital, things like that. But we want rehab, we want peer support, we want housing, we want employment. The health department and the Medicaid will understand it now that those things really are the determinants of health, and they need to be sort of looked at. So that's the benefit package. But now the other way that managed care, and the state needs to hold managed care plans to account, is what outcomes are they actually getting for people? It's no longer visits. So what are the outcomes? Well, how many people of color, for example, have you engaged? And if one plan or one provider is doing much better in that, then that's what should be rewarded. If plans are failing to engage people, let's not blame those people. Let's hold the provider to a higher standard of competence. Let's train them or hire providers who have those kind of staff, who speak that kind of language, who have that kind of understanding. We want to see, as part of the outcomes, the use of peer services. We want to see people's health improve. And we want to see people not so much in prisons and jails. We even have this. All these things are in what we have advocated for, or in the governor's document. Look at the next one. Even though you just saw that Kendra's law was expanded a little bit, on the other side of things, healthcare reform is actually supposed to reduce the use of court-ordered outpatient treatment by just being more effective and appealing and engaging. So that's really important to many of us. And there needs to be improved care transitions. People leaving hospital, jails, prisons, adult homes need to get better support. So the outcome is, did they get that support? Was there a reduction in court-ordered treatment? Are people staying out of jails and prisons? Are they living longer? Are they getting support? Does that extend to people of color, for example? The state has a waiver request to Washington. Right now it's in sort of rocky shape because of some other problems we're having, the state with federal Medicaid. You probably read in the papers about the possibility of New York having to give back a fair amount of money based on the billing model we had for people with developmental disabilities. That may impair our other request, which is an Medicaid redesign team waiver request, which is very exciting. The state went to the federal government and said, we could save you with our reforms $18 billion over 5 years. Give us a little more than half of that up front, and we'll build up our infrastructure and really be able to get you all those savings. But you got to invest in those savings. And look at what they asked for out of $10 billion over 5 years. $500 million to build on the health homes, to build up their infrastructure, how they use electronic records, how they coordinate care, including how to incorporate peer services, for example. $375 million for new service models, including, I believe, $6 million for peer service pilots in different parts of the state. And that's the 6 is only hopefully a fraction of what we'll see in new innovative models of healthcare, including other peer models of peer services. Look at this, almost three quarters of $1 billion, almost a tenth of the whole proposal for housing. Medicaid doesn't usually pay for housing, but the state is sold on that and is trying to sell the federal government on that. And then improving our workforce to be more about recovery and wellness and relapse prevention and cultural competence. So there's a $500 million on that. So we need to advocate for that as well. Advocacy is critical right now, and that's really up to all of us, not just a few of us here in Albany or what have you. All of us need to track what happens. Our future depends on how the state puts all of our money and our services in this pot called managed care and what rules they have to play by. So I'm optimistic, as you hopefully can hear, that there's a perfect storm that actually will hopefully see that money is spent better on better things for people with better outcomes in a more coordinated and better way. These things can happen, but they'll only happen if the benefit package and the outcome measures are clear, as I've just said earlier, and they really say you must have peer services, employment, and housing, for example. You must measure for recovery, not just whether people are taking medicine or got to see their doctor 7 days out of hospital, which are the ones we have now. And the money talks. The money's got to pay for recovery and not just chronic care and illness and hospital and medication. Money's got to reward recovery and recovery providers. So we've got to advocate for that. We've got to make sure that our mental health system is going into health care. And it's going to be overseen by the governor's office and the health department. We hope that OMH has a major role here, but OMH is folding a lot of its Medicaid money and some of its services are now going in this integrated banner. So we need to make sure that the Governor's Office and the Health Department gives OMH a front seat, as it's currently written, to play a major role in designing these plans and overseeing them. And we need stakeholders, like all of us, including people on the behavioral work group, to be convened, to monitor this, to evaluate it, to make sure that the design and the design is recovery-oriented and the oversight is strong. We also, we got to make sure that whatever money is in the mental health system, for example, now, isn't just lost and migrated into the healthcare system, or leaves working with really people with more serious sort of conditions and winds up being sucked up into wellness care for the so-called very well, for example. So we've got to track that really carefully. That there should be actually more mental health services, not less, in the integrated environment, because so many of our people are being readmitted, and we're spending a lot of money on folks. So that's clearly, this is a target group that needs more help, not less help, and help that's guided by OMH and the stakeholders and is properly funded. And because the health department oversees managed care plans, and the rules have to be strong, but DOH has to be a sheriff here. In some states, the health department sort of is asleep at the wheel, and the plans do what they want. That could prove disastrous. There's plans, there are good plans, and there are plans, and there are plans. And without strong rules, we could see a collapse of everything we've worked for and are hoping for if it isn't done right. Here's the timeline going into the future. As you know, I just showed you the timeline earlier for the health homes. This is the timeline into fully integrated managed care, where all the money is put into one pot and bid out to managed care plans under state rules. They're going to finalize that design by the spring of 2013. And if anybody from government is listening, just make sure that the stakeholders in the behavioral health work group are advising that process. That's going to happen. By the summer, they're going to finalize that contract I mentioned, and what are going to be the requirements and how the payment is going to flow. That's where the rubber meets the road. So we all got to watch that very carefully. And then they're going to publish the documents that are going to be sent out. They'll send them out in the summer of this year and say to plans, here are the rules you'll have to live by. We're going to put mental health and addiction in managed care, bid on it, and be prepared to show how you live by these rules and produce these outcomes with these kinds of services, with this kind of financing. And then fall and winter, by the end of this year, they'll pick the new plans of the future, upstate and downstate. And so all of a sudden, in many instances, some of these health plans, with or without behavioral health organizations, are going to oversee the system. The state's going to, essentially download its oversight over fee-for-service mental health and addiction and give it to plans who will integrate it and manage it. Now, they'll select them in 2013, and then somewhere in the spring of 2014, that's when life begins anew in this new world. That's the unprecedented change that I started out talking about. And we can't watch this enough. It affects everybody on this call, and it's got to be done right. And we have to be good advocates and good providers and good and informed sort of consumers or beneficiaries to make that happen. So my final slide is really saying this. In many ways, we've come a long way here. The stuff that many of us have talked about, recovery, wellness, diversion, prison reentry and diversion, for example, cultural competence, these things are no longer ahead of their time. They're actually right on time right now, but it's on us to really raise the bar and make sure our services are right and progressive, and that we market them well, and that above all we advocate to make sure that these changes are best for the people we serve and the values we stand for. I think that's it, Tony.
All right, thank you, Harvey. Well, while we're waiting for some questions to come in, I'm going to just move this around so people can just be patient with me just for a second.
Sure.
And I will pull up the questions. Unfortunately, my office is not particularly set up well because I'd be facing the other way.
Okay.
I would not be talking into the microphone, so that would not be good. So
no problem.
What's up? So while we give people a chance to put in some more questions, while you were talking, I identified a number of different things that we can send out to people after the webinar. So I'm thinking I'll send out some forms and information on psychiatric advance directives.
Great.
And the peer services fact sheet, is that available?
You know, it is, and I think if it's not on the Academy of Peer Services website, it should be soon, and
Okay.
it'll probably be on the NYAPRS and MEHEP websites.
Okay, I know they sent something out to me, and I got it.
Yeah,
So
we haven't distributed enough. I think we've just haven't really distributed.
yeah, so I can send that out to folks. I'll send out links for Rose House / People Incorporated, the Academy of Peer Services, as well as MHEP, and Harvey put his out there already, which is nyaprs.org. And let me also just encourage people that if they want to, you may want to check with the Department of Health, because there is a listserv for the Medicaid redesign team, and they do send out information so you can keep abreast of all of the new changes and everything that's happening.
And they're packed sort of pages on the Health Department Medicaid redesign team on health homes, on managed care plans. I didn't get into the plans that are going to be established for people on Medicaid and Medicare, but there are pages about that as well.
So I'm not sure, this was just some sort of stream of consciousness that I had while you were talking.
Sure.
So I'm not sure if it fits in here at all, but I'm thinking about that I haven't really heard much about prevention services and helping to prevent medical issues before they happen. Because I know in your earlier slide you were saying that quite a number of people who were using the services who had behavioral health issues, the emergency rooms, had medical issues. And I haven't heard a lot of talk about, are we asking about screenings? Are we asking about like a baseline mammogram for a younger person so that way they have something to refer to when they're older? And, colorectal things, and, all of those things to start to catch those things early. And one of the reasons why I like to promote that idea and to ask people to, if they've had those things, and to promote it, encourage people to do it, is it sends an underlying message of hope that, I expect you to live a long time, I expect you to recover, and I want you to be healthy physically when you do. So I think that sends a much more positive, and it raises the expectations in a much different way.
And I think you'll see that as one of the trends you're going to see is co-location of care or integration. So when you go to a mental health program, you'll see there'll be more medical professionals and medical issues addressed, and vice versa. If you go to a medical program, there'll be more mental health sensitivity and issues raised, hopefully.
All right. Okay, so we've got some questions coming in, so let me put them out there.
Okay.
First one is, what are the opportunities for recovery for persons with limited English proficiency and with a culture other than mainstream society or an English-driven system of care?
Well, I tried to speak to that a little bit. Again, to some degree, think about the money. This is about saving money by improving care. If people that are underengaged disproportionately are people of color and wind up we're spending too much money with not enough outcome, or people are in the wrong systems, then I think there'll be a higher focus on that. So there should be a greater interest in culturally competent services, particularly outreach and engagement. First figuring out what people want and need, coming to them, educating them, what they call health literacy, which is a big part of prevention, is educating people about healthcare and diseases and illnesses and things like that as well. So I expect there'll be a lot more. And I saw in the waiver training proposal a lot on cultural competence there.
Excellent. Next question is, any information on how to apply to provide OMSBUD services? I know money is to be released, but will there be an RFP?
Yes, and first the budget has to be approved. There's $3 million this year, and eventually there'll be $23 million at least over the next few years. And, if you get here's the good and bad news. The bad news is NYAPRS sends out normally 40 e-newses a day, which is a lot for people to absorb. But a lot of that information is normally in that on a real-time basis. And the good news is you'll probably learn about that there, and you can sign on at nyaprs.org, because I'll certainly post when those RFPs are out.
Excellent. And also I took the liberty in the survey that's going to pop up at the end of the webinar, I took the liberty of offering people an option to indicate whether or not they wanted to join the Consumer Affairs listserv, but also the NYAPRS listserv. So you'll get a list of that, and you can add the people there to just try and expedite it, because their listserv is absolutely just keeps you right informed and in the loop, and usually Harvey has the information before even people here at OMH do. So next thing is more of a statement, I believe, is still often seeing providers repeatedly stated consumer refuse services. Declined is a much more empowered term, as it begs a discussion about engagement and the reasons why. And that does bring up a pretty good issue about, are we reaching people in their language? Are we being sensitive to things? There is a great deal of distrust with the medical community with some people of color, and justifiably so, given some of the things that have happened. So I think that's a good point.
I think one of the great expectations of the new healthcare system is that it go to people, not sit in offices waiting for people and labeling them non-compliant when they don't come in. The burden is on the provider to engage people and do that successfully. And I think that's one of the biggest arguments we use against forced outpatient treatment is give the system a chance to work. This is not about non-compliance and coercion. It's about what are we doing to engage people and bring them in on their own terms and invest people in wellness.
And digging a little deeper. I may not really care about my physical health right now because I'm homeless. I'm trying to find an apartment. Or
Can't say that. Well, it's an excellent point. And exactly, engagement often starts too much around, we want you to say that you're mentally ill and take medicine. And when you're a homeless person, guess what? You want a house, not a pill. That's where you start. You're right.
Next question. What grants and or fundings are available to start a peer specialist program in the New York City HHC system and drive a recovery model in the city hospitals?
Well, again, as I said to you, I don't want to support a peer specialist model because I think it's too generic. I think HHC should look at the services that essentially the Academy of Peer Services is identifying, and the training can come out of the Academy in the next year, or maybe Howie the HARP down there, or maybe agencies. I know SUS, Community Access, and maybe HHC have their own training programs. But I hope it's not around peer specialists. I hope it's around the services we've talked about today.
All right. Next question. Where are we in New York State regarding peer certification curriculums and the Peer Academy? Any updates? And that actually may be a webinar in and of itself.
Yeah. I do think that, as I tried to say earlier, I think the Academy and the community, the greater community, has coalesced around, we need to define our services more clearly. We need to identify what competencies, what skills people should have to perform these specialty services. We need to come up with training standards. I don't know about certification, but I suspect it's coming. At some point, Medicaid managed care plans or even the state will look for some greater evidence that people meet a certain standard. If we're going to say that peers are bona fide professionals, most professionals come in with some sort of degree or certificate or something of that nature.
So I'm gonna mix a bunch of questions together and consolidate them because they're all basically around the same thing, and it has to do with, is there a list? So is there a list of programs that provide substance abuse disorders and MICA that use peer staff? Are there other health homes that are out there that are using peer staff? Is there a list of, so it's all about lists, is there a list of the programs that are using good cultural, competent, and bilingual services?
I don't think so right now, Tony. I think that certainly there's not a list of what health homes are using peer services. I don't think we know that yet, and I don't think many of them are doing it yet. And I'm not sure that there's a finite list of how many addiction programs are using peer recovery coaches or at how many plans are using peer bridgers, for example. But I think in the next couple of years it'll be clear.
Okay, next question is, what peer-run agencies, if any, are you aware of that were asked to sit at the table to help design the BHO/HARP program?
Hands Across Long Island, Ellen Helium is at that table. Laura Engel from For New York is at that table. Or is it Betty Courier, actually? And Harvey Rosenthal's at that table. So there's a number of us there. Could be more. And I will say, in fairness to OMH, they've been really open to getting feedback. So I don't know, maybe, Tony, you can identify within OMH who people could send their comments to? Someone here in the building, and give them a contact. But in the meantime, if you Google New York State Medicaid redesign, behavioral health work group, it's a long sentence, you'll see a document that all of us sort of fed into. And Tony, that'd be great to hand out to people. And you'll see some of the things I mentioned today around, the new system must promote recovery, choice, housing, employment, things like that. Have a look at that, and then if you have more comments, maybe Tony can give you the name of somebody in government that you can reach out to. If not, email me and I'll pass it on.
Okay. Next question, a little along on that line, is so New York Health Homes are not given more direction to leverage peers. Peers not involved in anything with the health home. At the moment, our peers will be earning $22,000, not $37,000. Harvey is unrealistic, I think. Harvey is unrealistic in our county. New York needs to provide money, and our health home is trying. It's hard for me to understand some of the words here. So it's trying, is like pulling teeth.
It is like pulling. Let me say a couple of things. This is just a joke, but I'd rather than unrealistic, why don't you say I'm being visionary? It's a joke. But what I really mean is this. I know that health homes, I think I've said that, very few of them are using their care management dollars to buy peers. Very few of them. But that's what I think we should be saying and focused on. The health department has said that it wants to encourage that. They need to do more in that. They had me speak to a group of health home leaders some time ago, but more needs to be done to really encourage them to do it. But I think when we go to managed care, and if the contracts are clear that peer workers need to be in there, and that peer workers demonstrate that they'll help the plan and the providers meet those outcomes, that's where I think you'll really see a demand for peer services. It's a little ahead of the curve right now. So I don't think, I'm being unrealistic. I'm trying to say where things should go, and some of us are getting it there, on an individual basis, but I think it's not there systemically. I know people are being paid 22, and NYAPRS and its OMH peer bridgers has not always been able to pay the kind of dollar. I'm just saying to you, the standard ought to be 37.5, and when NYAPRS, for example, puts in for a contract, we're asking for 37.5 now, whereas a couple of years ago we would have accepted less.
Well, I think, and doesn't this tie in with what you were talking about as far as like pulling data and as we take it on ourselves to advocate for them to use peers, showing them that it's in their best interest and showing them how they'll benefit from
Completely.
it, and having really good concrete, as you said, avoid sort of the generic peer specialist type terms, but some very concrete plans and some very concrete data to help change their mind, because generally, if you think of this is a business, and not all of us in nonprofit think in terms of business.
That's
but
right.
It is a business, and if you want to know how things work, you follow the money, and if you can show that you can save money and that there's good hard data. Anecdotes are good too, but they're not good enough. You need to have some good stuff, good data behind it, and there's plenty out there now. A lot more than there ever used to be to show that this is going to save you money.
Even if you take the data that were on these slides, and you may need links, find the sources of this data to really be taken seriously, and Tony and I can find those links for you. But this single sentence that I gave you earlier, I really feel strongly about. When you're going to promote peer services, it can't be vague and generic, and we have a drop-in center, or we have a wellness hour, or we have a health literacy program. You have to say, I think, as simple as, we provide this service. These are the key elements of this service. These are the kinds of people and conditions that this service is good for. This is the outcomes that we can achieve. This is the data to show that that's what's happened in the past, and this is what it'll cost. And that's where you say 37.5, or so you construct a budget that's, and you may have to push for that in the beginning. Remember that the payers may even want peer services, but they don't know what it is. And if the first thing they hear is it's a peer specialist generic thing, I think that's, again, a really missed opportunity.
Okay, next question is, how do we propose and frame our services like navigation and peer support to health homes as an option for those care coordination dollars?
I think the term wellness coach, if you're talking to a health home, I would use the word wellness coach. They've come to understand that it's commonly accepted in healthcare that a coach engages people and teaches them or supports them to make healthcare changes. So, navigator is another word. I think I have that on the slide for health coach. That's also well known, but I think language is really important. And again, as you say, Tony, talking about it in a really business-ready, a marketable way, and using clear language. Peer specialist, think about it. You're talking to a plan and you say you have a peer specialist. It sounds vague. You tell them you have a wellness coach. You show them data. You give some outcomes about it. Their eyes open. I've been in rooms with plans, and when you present in this way, people become very interested.
Okay, next question. Can a consumer be referred to an outpatient provider that is affiliated with a health home if they themselves are not enrolled in that health home?
Say that again, please.
Can a consumer be referred to an outpatient provider that is affiliated with a health home if they themselves are not enrolled in that health home?
Yes, I think providers have their freestanding identity outside of the health home. Yeah.
Next question is, and I think I can answer this, is why is the Academy only available to peers already working as a peer? When I asked Yumi, that is not accurate. Anybody can join up in the Peer Services Academy and start attending.
Go to academyofpeerservices.org.
Yep.
Any peer, a peer who wants to work in the field, who is working in the field, who wants to move ahead in the field, that's the Academy's for them.
I know there was maybe some misinformation early on in the beginning, but it is very broadly put out there. So, next question is, what are the funding opportunities for newly developed peer-run services, and what technical assistance is available for newly developed peer-run operated programs? I'm guessing in terms of the health homes.
Again, health homes, I think, are limited, as the person said earlier in the question. Right now, they haven't yet really embraced it, but managed health plans and behavioral health organizations, who will be essentially the new bosses by 2014, that's where you want to go market. Find out who the health plan is in your area. Excelis, Fidelis, Affinity, Emblem. Go have a meeting with them. Come prepared to make a really good first impression. Don't come there talking vagary. Have your business plan, have your data, have your model, have some idea of what it might cost. Start now with the health plans. Talk to the behavioral health organizations in your region. If you don't know who they are, ask Tony or me, and we'll get you the names, or keep researching, because that's the environment you're in now. You have to do some homework.
All right, next question, and this is a great question. We have been working to integrate peers into our treatment center. We have had mixed responses from the staff in terms of their willingness to collaborate with a peer. Much of this is a lack of awareness of how peers can contribute, but it is certainly an attitude that needs to be addressed. What is NYAPRS or other agencies doing to help educate behavioral health providers about how to make this work?
There isn't enough education going on, and I think education is critical. When we, years ago, put peer bridging into state hospitals, we actually had to come back to OMH and ask for more money to hire we would call them peer support specialists. I don't use that term anymore. But they went into state hospitals and trained the staff who were either threatened or hostile or didn't believe, or had actually seen some of those folks in those services and just wasn't prepared to believe that they were in recovery and were really job ready. So I think we do some training in that area, but I don't think there's enough of it going on. And it could be a great product for the Academy of Peer Service to come up with some curriculum to train providers about what real peer support is and what peers do and how they should be supported and what they're capable of.
Yeah, that's a topic that's near and dear to me as far as integrating peer services and the staff attitudes and things like that. So just a little shameless plug here. So we had started doing these webinars about 5 years ago in January, about 5 years ago. And the first one was about ACT Team Peer Specialists, and it was about a bunch of listening forums that we had done throughout the state. So this is how the state works. We got all that information, all of it's still true today, and we are in the process of, and we're probably about 3/4 of the way through, working with the Center for Practice Innovations, developing a module based on those, primarily on those forums, about how to use peer specialists on ACT teams. Now, although it says ACT teams, it is pretty generic, and it's easily transferable to anywhere, and it does address the issue of hiring peers for the first time, or when you've hired peers in the past and maybe you've had a bad experience, you know, and there's a reluctance to hire peers. So it does address a lot of that stuff. So that will be coming up online, and that is also open to the public as well. You need to get a username and password, much like the Academy for Peer Services, but that will be available.
I think that these are going to be the professions we think they can be. We need to really up the training and make sure people are fully trained and prepared to play these substantial roles. Peer services, I think, are no longer, should be considered an entry level, a first job for somebody just back into the workforce who are just finding their way around. I think it'll actually be a mutual disadvantage. The person might get over their head, and the plans and the providers will be disappointed if they're not clear on what a peer can do and they're looking for that person to show them that.
Okay, so here's another question. Are we in danger of measuring recovery in terms of dollars? Reducing ER visits, etc., correlates with recovery and quality of life improvement, but they are not the same thing. It seems as if, e.g., the hospital days for the biggest spenders are reduced, there won't be incentives to provide authentically recovery-oriented services for the greater part of the population.
I think it's a real good point, and I think you're absolutely right that if the whole focus is just on keeping people in hospital emergency rooms, that's only half the battle, right? I mean, it's as you say, it's what people are doing instead and how their lives are being enriched and how they're growing. But I think, you know, some of the things I've tried to say today are reinvestment of those savings to grow the kind of services you're talking about, and the Medicaid waivers emphasis on expanding housing and peer support. There's room for the community to be built up and ramped up. But again, we have to be very focused advocates to make sure that it happens.
Okay, and I know we're running over a little bit, and I do want to get to some of the questions if Harvey is able to, just for maybe like another 5 minutes or so, if that's possible. Sure. Thank you. So here's the next question. So as a certified peer specialist and advanced peer services advocate, there are 2 programs in that person's county, are you saying that my certification is now useless?
I'm not saying it's useless. I'm just sort of arguing that we move to the next level and we get more specific. Peer specialists is where peer services have begun in most parts of the country. So, but I'm just saying that in the next phase, I hope, and some of us here in New York hope, that we get more specific. So no, I think that's a great starting point, and it's a great certification to demonstrate, hard won, I'm sure, and to be respected. We're just advocating in the next phase of this that we get more specific about the competencies. You don't hear something called mental health specialist. You hear things like social worker or I don't know what, rehab counselor. So why not wellness coach or bridger rather than specialist?
Okay, so one more question, a statement, and then an announcement for next month's webinar. Okay, so how far are we from self-directed care vouchers in New York State?
Well, that will depend on what's in that expectation of plans that's coming out mid-year. We're advocating for self-direction to be in there, and honestly, from what I can tell, OMH is thinking that way as well. But, you know, how much of it is done, how it's done, how closely plans are expected to do it, how they're overseen in doing it. I think it's a huge opening, though, and I think we, again, you know, a number of you want to sit at the table, or you want to have, you know, have your voice. You've got to. We need your voice. It can't be a few of us sitting at tables. More and more of you locally in your counties, in your field offices with OMH, you know, in any demonstrations and discussions, you need to push to make sure that the managed care rules allow for that kind of flexibility, employment, peer support, housing, cultural competence, and self-direction.
Okay, and then this is a statement. It seems like a good thing to end on. So this webinar is right on time. Thank you so much, Harvey Rosenthal, for this presentation. So clear and helpful. Lots of light bulbs going off in my head. I am a new program director working with a peer advisory board and fiduciary to build and manage a peer recovery program that basically will extend a lifeline to people in recovery to assist them in identifying, remembering, or discovering their own true passions, specifically those that will ignite a spark of life and purpose. In doing so, we
Sounds like a recovery center.
It sounds like a recovery center. In doing so, we hope to facilitate a passageway from recovery in the system to recovery in the community. Based on your presentation, I am hopeful we are on the right path and the future of healthcare will support this. Thank you, thank you, thank you. So, you're very welcome. All right, so thank you very much, Harvey. I think that summarized what I was going to say very well. So as far as, you know, thanking you and doing a good job. So
Thank
this
you,
was,
Tony.
again, there will be a short survey afterwards. There should be a thing that will pop up. If it does not pop up and you want to give me feedback, you'll get an email automatically generated by the GoToWebinar people, and you can always email me back and I will respond. Next month, I get to do a webinar,
Right.
And I haven't done one in quite a while, so I'm going to work on understanding the jargon, the concepts, and the structure of the New York State mental health system. It is certainly been described as fragmented and confusing. A lot of times when people first come into contact with the system, they are it's not always a positive experience. They report usually very negative experience, and those are very, very imprinting types of things when you first come in, because you're looking for help, and if you don't feel like you got the help that you were looking for, it can be a big turnoff and create a lot of suffering, and that I think is unnecessary. So hopefully I'll be able to describe and put together all the different things. I tend to think in boxes, and everything goes in its box, and then I try to connect the boxes together. So hopefully that style will work for you to help you with your advocacy and to help you with your understanding of, you know, what door to go into. We do try to promote the no wrong door theory, but you know, that is certainly an ideal that we would like, but it's in reality it's not being followed. So with that, I want to thank everyone for coming today. Again, thank you, Harvey. It's been a pleasure doing this with you. This is the first time we worked together on a webinar, and that was really cool. And take care, everyone, and you'll get a link to the recorded version of this.